I think that's one of the reasons why you're seeing the push toward unionization in the United States, because people are starting to say, if you're going to treat me like workforce and not a learner, I'm going to act like a worker, and I'm going to fight for better conditions and better rights. So it makes total sense when you think about it.
Welcome back to the podcast for Doctors by Doctors. I'm Dr. Michael Jerkins.
I'm Dr. Ned Palmer.
And Ned, how's things going? How's life?
Things are going great. It's wonderful. It's summer. It's transition season for our new interns and new residents out there. So we're seeing a lot of new faces in the hospital. It's a really vibrant time in hospital-based medicine.
Yeah, and even outpatient. Don't have any bias towards us outpatient doctors, but it's also an exciting time with folks we're seeing. I talked with a medical student just today who just went into their fourth year, and they were starting to think about residency applications and stuff. So it's a fun time. I will say it's probably more fun being on this side of it than when we were going through it. It wasn't quite, the word fun is not what I would have used to describe it.
I had a lot of words that started with variations of F, and I don't think fun was one of them. Stressful.
Stressful.
You know? That is an F.
Yes, that's exactly what I was thinking.
Yeah. See?
Totally. What's interesting about that, though, as a good segue, though, as our guest today is Dr. Ben Kinnear, who spends a lot of time thinking about what is stressful to trainees. How do we educate and train trainees to become great doctors? And I think what's really fascinating about his work is he focuses on what's broken and could be improved in our current training system, and things that maybe you and I dealt with in training, actively finding out, hey, actually, maybe we should rethink some of this.
I think my other favorite piece about Dr. Kinnear's work is around Pumpfrage, another F word, just saying. And really actually diving into, and with Dr. Kinnear, really actually diving into actionable changes that are happening in medicine today. These aren't happening in an academic session on a whiteboard somewhere. These are actual residency programs, training programs, fellowship programs that are putting these changes into place, learning, iterating, and trying to improve on healthcare overall. It's really not just an academic exercise. This is tangible. There are programs out there that are making hours-based changes, competency-based changes, time-based changes to their residency programs, and exploring what all the different downstream effects are that we need to solve for if we're ever to roll this out more broadly.
Ned, am I going to learn what Pumpfrage means? Do I have to keep listening? I'm still guessing. What is that?
You got to stay tuned. I think Dr. Kinnear describes it better than I do.
Okay, I guess we'll have to talk to him. Excellent. We are happy to invite to the podcast Dr. Kinnear. Let's get to it. We welcome Dr. Ben Kinnear to the podcast. I'm very excited to have him here as a guest. A few things about Ben. Ben is a Med-Peds hospitalist based in Cincinnati, Ohio. He's also the program director for the Med-Peds residency programs there. He has lots of interests, including competency-based medical education, novel assessment strategies, coaching. He's also a PhD candidate studying validity argumentation and argumentation theory, which I can't wait for him to explain to me what that means. He also is well-balanced. He does a lot of things outside of medicine. He spends a lot of his free time with his wife and two daughters, hiking, playing board games, traveling. I think one of the most important things about Ben is that not only is he a St. Louis Cardinals fanatic, but he also believes that mint-flavored ice cream is the best ice cream flavor that exists in the world today. Dr. Ben Kinnear, welcome to the podcast. Did I get that right?
Okay, so great. Yeah, so great to be here with you guys. Boy, that one hurt. That one hurt. I do have to offer that correction. I think that mint ice cream makes no sense. I think mint should be reserved for toothpaste and gum. And why anybody would ever want to have it as a dessert makes no sense to me. Candy canes don't make sense to me beyond decoration. It just doesn't make any sense. But yes, everything else was great.
Okay.
Good podcast, Ben. Thanks for coming. Okay.
I got to get with our team that writes these intros. I'm so sorry I messed that up. But seriously, though, Ben, we are very excited to have you here. I think a lot of our listeners deal with a lot of issues related to medical education, maybe not currently, but how they were educated to become doctors. And I couldn't think of someone who has more interesting takes and more insights than yourself on this topic. So we're happy you're here.
I'm so excited to be here. And I don't know if the listeners know, but I go way back with you all. I was your associate program director during training. And so speaking of medical education, I got to see you two through your highs and your lows of training when you were in the thick of it, and have many a story that I probably am not allowed to share because this is your podcast and I'm sure it would get cut if I told them. But yeah, it's so fun to see you all doing what you're doing and changing the world, and excited to have this conversation with you.
Well, I'm just excited that there were some highs in there. So thank you for that. I thought it was mostly lows. So that's very, very exciting. So a couple of things I wanted to start talking about with you, Ben, where we get a lot of questions on, is this concept of competency-based education. And I could explain it in a very dumbed down way. And then you can tell me how wrong I am. Maybe that's a good way to introduce this. And it's basically the idea that in training doctors, not everybody learns at the same speed. So why do we have a set time that everyone has to complete? And then we all of a sudden say, you're ready. Is that a dumbed down way to think about it?
No, let me reframe a little bit. So competency-based education, which I'm sure many of your listeners have heard that term, and it's kind of turned into a nonsense buzzword. In its core is a philosophy of training that says, let's focus on the outcomes of education, which sounds so obvious, right? But it's interesting. That's actually not how education has worked for most of modern civilization. It's most of the time education is focused on standardizing the process. So let's get a standard curriculum. Everybody does that. And then if you come out the other side of it, we presume that you can do what you say you can do. Competency-based education, which started sometime in the mid-20th century in the United States, says, let's make sure that the outcomes of training are getting where we want to go. And so once you start with that foundational principle, you start getting to tensions like, okay, if we want everybody to hit a certain outcome, the only way we can have training for the same amount of time for everyone is if everybody progresses at the same rate. And now that we've been studying that, we know that's not true, right? And anybody who's tried to learn a skill knows that we don't learn things at the same time. If the three of us tried to learn to juggle or learn to solve a Rubik's Cube or really anything, we would progress at different rates. And medical education is no different. People come in different starting points and they have different rates of growth and different struggles. And so if you start to want to standardize the outcomes of training, the only way to do that is if you start being flexible in other places. And that's where I spent a lot of time thinking about in recent years is, if we really want to make sure that every single person who graduates medical training is truly ready to provide high quality care for patients, then we probably should rethink how training is structured. Because right now, there's some pretty good evidence that medical education, whether it's medical school or residency or beyond, that we not infrequently graduate people that we don't fully trust to do the job. And part of the reason for that is because we feel obligated to with these time-based structures. So I spent a lot of time thinking about what would it look like if training were more flexible in timing, where, for example, maybe some people need 3 years of residency, maybe some people need 4, maybe some people need 2, even if they're doing the same type of training. And that obviously brings up a whole host of challenges and questions and other things. So see, competency-based education, it's all about the outcomes. And then once you pin yourself to that, there are lots of other kind of downstream effects that can follow.
What areas have you seen some of the most dynamic variability in as you've kind of peeled back competency training? Where, I think of, we went through very structured training. It was 2 months of NICU, a month of PICU, where do you see the variability? Because there were certain blocks about social determinants of healthcare. There were certain blocks about QA, QI, which I remember with you personally. Where's the variability? Is it clinical? Is it like the health adjacent things that are critical to being a doctor, but not necessarily clinical?
Yeah, I think it's everything. Some people, it's like the big picture, are you ready, are you not? Those kind of holistic judgments we make. But there are people who've done studies on things like learning to read an EKG or learning to read an ankle x-ray. And there's a guy who's currently at Harvard. His name is Martin Pusick. He's a pediatric emergency medicine doctor. And he does some really cool work around learning curves where he will, and other people do this work too, but he essentially studies what does it look like in terms of the skill that you gain over time with repeated practice. And he's shown, even with specific skills, there's a lot of variability between people. And that kind of idea translates across specific skills, holistic things, all sorts of stuff. So whether it's communication skills, specific procedural skills, clinical reasoning, I think all of the things, there's a wide range of variability. And I think what's challenging is, I think how fast we grow is really context dependent. So you can't always look back at how somebody did like in medical school or in undergraduate and say, this is how they're going to grow in my context, because so much of how we do depends on the context we're in. Like you two, we really thought both of you were going to thrive here. And then, as Michael alluded to, once you got here, it was a disaster.
Oh, the wheels came off so hard. Yeah,
it was a disaster. So who could have predicted that? You both looked great on paper when we were taking you into the program,
I hope there's a lesson learned in there for you in the selection process.
Well, so I guess there's been some medical schools that have varied the duration in which they graduate students. Have you seen anybody in the residency space kind of take up this cause and actually experiment with it and see how it goes?
Yeah, there are a few in the United States. There are a few pilots. Mass General and Brigham and Women's Brigham and Women's and Boston Children up in Boston have a pilot going. It's called Promotion in Place. There's another one that actually involved multiple pediatric institutions called EPAC that they have done some time variable training that bled into residency as well. We did one here in Cincinnati with our internal medicine residency. And there are a few others out there. There's one in surgery. There's one in plastic surgery. So there are little pockets of trying to figure out how to make this work. One of the things that's really challenging is so much of how we do education is based on time. Like how we pay for education is based on time and training, and it's very rigid. How we staff our hospitals is based on time and training because we tend to use learners as workforce. And if you start to build flexibility, and it gets really challenging to staff things like clinics and wards and consult teams. And so basically our entire world is based around this time-based education model. And when you try to deviate out of that, it gets really tricky to do that beyond just little pilots. And so they exist and they're out there. And I think it's a good first step in trying to understand what are the educational effects of time variability. Like what does that do to the mind of a learner, to the practical implications, to the challenges, and all sorts of things. I will say Canada is a little bit ahead of us in this. They have something called competency by design, which is the broad term for their competency-based initiatives. And
CBD.
They have
CBD. CBD. Okay. All right. Canada's been big on first. CBD for.
Nope. Canada did their CBD before we did the CBD thing. So I think they own that. But yeah, they have been doing a little bit more time variability longer than we have on like a broader kind of national scale. But it just makes so much sense. When you think about how humans work, why would we ever build a system that presumes that we all grow at the same rate? It doesn't make sense. And I love sports. And so I tend to think in terms of sports. Anybody who's listening to this who knows how professional sports work, when you get pulled into a minor league system to prepare you to go to a professional team, you're not on a rigid time-based track that you train and progress and grow until you're ready. And some people are never ready and they don't make it. And I think those are two things that we could do better with in medical education. One, give people the time they need, whether that's shorter or longer. And two, doing a better job of helping people when they're not going to make it. Because as you all probably see, given what you do, there's a huge financial risk people take going into medicine. And that can make you feel trapped when you start to realize that you might not make it.
And then there's some conflicting pressures there. There's a lot to unpack there, but maybe just sticking with that last point, medical schools, residency programs, attrition rate is a negative mark, right, against a program. And so failing people out or flaming people out is seen as a negative mark against the program, as though you ought to have perfect selection. It's almost laughable in medical schools where they're looking at, early 20s individuals. You have no idea what their competency or capabilities are other than undergrad. Maybe you are a little bit better in residency. Two of us notable exceptions for you, but really it's it's all based off this assumption of perfect selection. And so, the metrics, it's the tail wagging the dog a little bit, right? Of if your metric is this and you're trying to optimize towards it for the way that the program presents itself, it's going to be hard to get trainees next year if you had to fail half of them, right? Or, heaven forbid that happen, of course.
100%. I think that, medical schools and residency programs are under tremendous pressure to not fail people and to get it right. And I think there's the selection of programs selecting students, but I also think there's learners selecting their career. So once you make that leap and you take out those loans, you're pretty committed, because there's an idea out there in education called the compassionate off-ramp. How do we give people an off-ramp out of the medical education highway once they realize either they're not going to make it, or maybe they just don't want to do it. Maybe you get in there and you're like, this isn't what I want to do with my life. Maybe you go start a new financial company, who knows? But how do we do a better job and not just say, sorry, you didn't make it, or you don't want to do this, and good luck with all your debt. So I think there's a selection pressure both ways. I think institutions and programs feel like they have to get it right, and they're judged based on whether people fail or whether they progress to the residency or the fellowship or the career that's prestigious. And I think learners also feel a tremendous amount of pressure to pick the right thing. And once they've chosen, they're kind of committed. So that's why I think it's so amazing. I've heard about your program that Panacea Financial has guaranteed that every person who decides they don't want to do medical school anymore, I've heard you all said you're going to forgive their loans. Is that true?
That is a very interesting take, and that is unfortunately not true. But I appreciate the suggestion, Dr. Kinnear. I did have a question, though, because Dr. Carmody, who was on the show earlier, had mentioned some talk, I'm not sure how you feel about this, of work hours being lowered as far as maximum work hours from 80 over 4 weeks on average to something lower. And the reason I asked that and bring this up in this conversation is it brings another aspect of time into it, because if you lower the duty hours, could you, in theory, limit the growth of certain individuals in these time variable trainings, and maybe even extend longer the time it took for them to be fully trained? Is that something you've seen? I don't know in Canada if they do have duty hours restrictions or not, and what that impact is.
Yeah, I actually don't know about duty hours in Canada either. But yeah, you're seeing this already with the American Board of Family Medicine looking to potentially extend training programs, and emergency medicine, has gone from 3-year toward 4-year programs. I do think there's always going to be a trade-off. If you reduce work hours, can you get the experience and the exposure and the training that you need in the same amount of years? For some people, the answer is probably yes. And for some people, the answer is almost certainly no. And so it does become a trade-off. And imagine if we had a system that had so much flexibility that you could choose which track you want to be on. Do you want to be in that pressure cooker of 80-hour weeks for, shortening your training for a year? Or do you want to say, no, I want to have other interests in my life. I want to, spend time with my family, or, God forbid, I want to have a good mental and physical health. And so therefore I'd like to work a normal amount of hours, and then maybe I'll extend my training a little bit longer. That would be a wonderful choice to be able to give to people. But I think one of the two fundamental pressures that really make that hard is, one, again, especially graduate medical education, the residency world, is funded through government funds, and it's very tightly linked to number of spots and institutional caps, and it's a very rigid system. And the second thing is that, again, we use learners as workforce. So hospitals and clinical divisions and all these people rely on, especially residents many times, to say, make sure I have those warm bodies to take care of these patients. And if you start giving people options you start varying how many residents are available, it really starts to muck with the whole system. And so I think that's one of the reasons why you're seeing the push toward unionization in the United States, because people are starting to say, if you're going to treat me like workforce and not a learner, I'm going to act like a worker, and I'm going to fight for better conditions and better rights. So it makes total sense when you think about it. And if you start making the argument around education, then maybe we should start treating our learners more like learners, not just workforce.
I feel like we've been slowly rebelling against the Osler model for now more than 100 years, right? Of like, the house staff is because they live in house. They are interns because they've been interned. They're residents because they live there. With the rise of the unionization model and like the focus of the workforce, are they tackling, I've certainly seen some of the talking points that they have. I don't know if I've seen work hours specifically on it, certainly work quality and condition of labor. Have you seen that the unions, especially, I think New York certainly has a couple that have launched more recently. Are they tackling the work hour, just the length of time? Are they going after that as one of the metrics?
That's a great question. To be completely honest, I am not an expert in the world of unionization. We aren't unionized here in Cincinnati yet. I say that because I think most places will be unionized in the future. And so I don't know exactly what specific gains or benefits different institutions have gotten from that. I do think that many institutions, unless there are other pressures, will continue to schedule residents to the maximum allowable degree based on whatever cap the ACGME sets. So right now, the ACGME, which is the accrediting body, says you cannot work somebody more than 80 hours per week averaged over 4 weeks. And so you see a lot of residency programs bumping up against that, not on every clinical rotation, but on the busy ones. And until there's an incentive to move away from that, you'll still see a lot of residencies and specialties bumping up against that. I think unionization, in my mind, could push people at an institutional level to move away from that. But that's probably very institution by institution. I've not heard anything about any kind of organized labor or unions advocating toward accrediting bodies. Maybe that exists. I don't know. I haven't heard about it.
Yeah. And as long as residents are revenue generating, right, and then you're always going to have that incentivization to push them, maybe not revenue generating, but revenue protecting in terms of you can keep the lights on, keep the ward alive. You don't have to staff it with other bodies.
You know, that's a really interesting question. I tried to dive into this about are residents, do residents save the institution money or not? And it's really a harder question to answer than you might think. In fact, one of your past guests, Dr. Carmody, had a really good article on this on his Sheriff of Sodium blog, which if people have not gone to his blog, it's pretty incredible. I highly recommend it. But when you look into all the different money that gets put into a residency program, and then trying to estimate all of the cost savings in terms of, we've got a resident staffing this service, so you don't have to pay an attending or an advanced practice provider or something like that. It's actually really hard. Some places I've seen say, yes, residents save institutions money. Other places actually say they cost them money. And so my takeaway has been it's really kind of hard to tell in any given situation. And I don't want to speak for Dr. Carmody, but I think that was kind of the takeaway of his article as well, is your gut reaction, at least my gut reaction is, the residents are saving the institution so much money because you don't have to pay attendings to do that job. But there are a lot of costs that come with a training program as well. And I think a lot of places it actually kind of comes out in the wash.
Or is so service line dependent that it may be difficult to, internal medicine different than operative or interventional residencies and training programs as well. So.
Like at our program, when you all were there, I remember you refused to do any ICU rotations unless you got a weekly mani-pedi, and we had to have it on site. So we had to actually pay a mani-pedi company to come into our resident lounge to just start hacking away at your cuticles. And Ned, your cuticles, I've heard, are like concrete. So like,
that was the best they ever looked. I've never gotten back that good, man. I needed institutional support.
This is an advertisement for Cincinnati Med-Peds. Come to us and we will get you personalized mani-pedi services while you're on call.
Cincinnati Mani-Pedis.
How come no one told me about this on my interview day? Ben, I think you were actually the person who showed us around on our interview day, and I'm a little disappointed.
Well, I saw your cuticles. You have excellent cuticles,
Oh,
Michael.
Thank you. Thank you.
You did not need them, but I mean, have you seen Ned's toenails?
I try not to. But
right.
I would say this is, I'm curious if you've had any residents since us that have gone 4 to 5 months without reporting their duty hours. Is that a record?
Maybe some person on this call has done that.
Yeah, I'm not saying who did that, but I'm just saying, is that common?
Yes, there's always one. There's always at least one person who just doesn't do it. And I'll be honest, my view on duty hours, the idea behind it is wonderful. It's to protect our residents, right? What it tends to turn into at almost every program is a never-ending nag session, trying to get people to do this administrative task of logging hours, which even with good intention are probably not accurate. And so it's one of my least favorite things as a program director is to, when a resident is working really hard and they're tired and they're focusing on other more important things, to say, don't forget to log your duty hours. It sucks a little bit of my soul away every time. But I think there are other ways people try to tackle that with automation and things. But yeah, it's those kind of tasks that I think are just they just make you want to, punch a wall.
Yeah, instead of punching a wall, I just put 8 to 5 Monday through Friday, and I never really got asked about it. So I'm not advocating for that if there's any residents listening, but it worked out okay.
Yes, please don't do that. I will say, when it's done well, it's actually, duty hours are an awesome tool for the program to go back to the institution or to a specific rotation and say, hey, our residents are breaking duty hours here. You need to change something. And we have had that happen several times. So it can be a change initiative. The problem is relying on residents to log their own hours. Again, it's just like an administrative, like if every day I had to go home and log the hours I worked, I would forget to do it half the time. And when I did log it, they wouldn't be accurate. So we've actually looked into moving toward more automated systems, but then you're trying to balance like being a nanny state where you're tracking where people are and when they're going or when they're logging into the electronic health record. And so that's a balance too.
Can I ask, on these programs that are trying this, these pockets of folks who are trying time variable training in the United States, what have they seen? I guess, what is a measure of success they're even looking at?
Yeah, I think what I have seen out there, and based on our experience here, I would say that it is possible to do from an education standpoint. I think assessment systems are getting advanced enough that you can make a defensible decision about someone's readiness for practice without relying on time and training. Now, that doesn't mean that time and training plays no role, because I think no matter how good your assessment system is, there's still some aspect of our thinking that says, has this person been around? Like, if you walked into be a resident for 3 months and you perform really well, it's hard for me to say after 3 months you're ready to be an attending. But there's at least variability in there. And then people have also found that most learners or many learners respond well to it. They find it motivating. They seek out assessment more. They seek out feedback more. They appreciate the challenge of being kept on the edge of their ability. So if you're a very advanced practitioner, much like both of you were, by the way, I know I'm throwing a lot of shade on this podcast, but you were both excellent physicians while you were here and probably could have advanced faster than 4 years of residency, if I'm totally honest. If you're one of those people, being kept at the edge of your skill by advancing to the level of your competence is a really motivating and fruitful thing. And I think if we had a system that allowed people to take more time to do that without it being a big stigmatized, weird problem that causes huge delays in, the rotations that you have to do in the future, or you stick out like a sore thumb because everybody else is on a specific track, I think that would be beneficial for people too. So it's not just going faster and slower, that not just going faster, but also if you need more time. The last thing I'll say is we did in our pilot here, we found two other really interesting things. One thing was there was some effect for some learners that if you put time variability on the table, they really get focused on how quickly they can move through the program. And that makes sense, right? Because residency is hard, it's long hours, and you don't make a lot of money, and you want to get done. And I think if all you focus on is going as fast as possible, you lose a little bit of the sense of growth and curiosity. You become a little bit less willing to be vulnerable and ask questions because you're just like, I just want to perform to get out of here as fast as I can. And so that didn't happen with everyone, but some people did start to feel that pressure. So that is something I think we would need to learn to balance if we were going to pursue this model of training. And then the other thing we found was, and this was really fascinating to me, there is some evidence out there that when the people who decide that you are ready to move out of residency, that's called a competency committee. That's what we call these committees in the United States. When the competency committee sits down to make decisions about learners, there's evidence out there in the world that a lot of times it's not a very active decision. In other words, they don't look for evidence to show you are ready. They just look to make sure that there's not evidence that you're not ready, right? So they're looking for, exactly, they're looking for an absence of red flags rather than has this person proved themselves. And that's kind of a consequence of our time-based system. Once we went time variable, it flipped, and our competency committee started saying, we need evidence that this person is ready. And if they haven't shown it, we're not going to promote them. And so just that simple tweak of removing time as a safety net of decision-making forced people to be more active with their decision-making, which I think is what we would want for everyone, right? If I'm gonna have my kid go to a hospital and be taken care of by a doctor, I don't want them to be graduated just because there was no red flags. I want them to be graduated because they have shown they are competent. And so simply changing the way of thinking from they've been here long enough and there were no major problems, they're probably fine, to I need to make sure they have shown that they are competent to do these things, really had a profound effect on the decision-making in the competency committees.
It's like, you wouldn't want your pilot and your taking off said, I just graduated. They told me there's no red flags. We should be okay.
That's right. That's exactly right. And so, why can we not do that in medicine? And again, I think there's a little bit of cause and effect because we have relied on time and training as our measuring stick for so long. We have kind of let the idea of active decision competence wither on the vine. And it's only when you remove that measuring stick and say, find a different way of assessing when somebody is ready that people become active about it. So Dan Schumacher, for any of your listeners who really want to do a med-ed deep dive, Dan Schumacher has published some really interesting stuff on this, which was kind of alarming when you think about it, that so many places are graduating people just based on the absence of red flags.
Over time. Yeah, the absence of red flags over time. Has anybody, I've thought about this a lot when, Michael and I were talking about you coming on the show, we knew time variable training was going to be a big topic. I feel like I've heard versions of this more in fellowship, where they've been able to adopt a bit more of a blended, fellowship tends to be clinical and academic, a bit more blended. And oftentimes a lot of fellows tend to come out of it with something tangible on the academic side. Maybe not like a full graduate degree, but a diplomat or a certificate of something like that. Has anybody looked at layering this in? Like if, let's say it's a 4-year training program, for instance, Med-Peds, and you're ahead of the curve, you could use that extra time. Like it's still a 4-year program, but you get to build other gold stars that are helpful towards resume building, your future that you're trying to build towards, right? Like what's the carrot, for going faster on top of it? Because if in reality, from a scheduling standpoint, you can't get let out early, what could you layer in there for other carrots?
Well, I think that, so I have not seen anything explicitly bridging people into fellowship, although we already kind of have a version of this with physician scientist programs. So for people who are not familiar, there's something called physician scientist training programs where, for example, instead of 3 years of internal medicine training, you would at the very beginning sign up for a program where you do 2 years of internal medicine training, and then you go into your, let's say, cardiology fellowship, and you're going to be a physician scientist who has a research-focused career, but you essentially are starting your fellowship early. So these kind of models already exist, but again, you have to make that decision up front. It's not a matter of you just sign on and you're going to train till you're competent, and then you move on to the next thing. So yeah, I think all of those models could work, but so many of them are bounded by, again, all these regulations. Like, for example, a lot of the time-based regulations are for board eligibility. So to do board eligibility, you have to be in training for so many months, and if you don't establish that early on by doing a physician scientist training program, then to your point, you can say you're ready, but then you really can't transition on to the next thing. If we start working with some of our certifying and accrediting bodies to loosen those regulations, there's no reason you couldn't be flexible with all these things.
It's physician scientist training program makes me think of a time in residency where I was the senior resident. My attending was a MD PhD. The intern was an MD PhD. Both of my med students were PhDs. And it was this weird thing where I was the senior, but also maybe the dumbest one on the team. And at the end of the month, they gave me a certificate that said I was the most important senior on the team. So it was very nice. But it made me think about a physician scientist. But I did want to ask a question, Ben, because I know you are very active, obviously, in your research and generating really interesting evidence-based takes. And recently, there was an article that you published that has gotten some attention on X, formerly known as Twitter. And I wanted to bring up this. And I recognize that the title of this practice or the label is not appropriate, but colloquially is known as pimping in medical education and other forms of education too, of this asking people questions, putting them on the spot. It can be fairly caustic. It obviously comes in lots of different forms and flavors, but tell us a little bit about what you guys wrote about and what you found about this.
Yeah, thanks for bringing that up. And to the point of what it's called, why don't henceforth we can call it toxic quizzing, which is what we called it in our paper. Interestingly, about the terminology, by the way, when you read about this practice of pimping, people start to try to rationalize it. Where did it come from? And there are some articles that say it comes from the German word Pumpfrage, which I'm sure I'm saying wrong. I don't know if either of you speak German.
Yeah, it's a question. Yeah, like aggressive questioning.
Yes.
Yeah.
Thank you. But it turns out that's actually not where the term came from in medical education. It actually does have very kind of misogynistic power dynamic overtones. So toxic quizzing, we wrote this article. It's in a section of a journal called Journal of Hospital Medicine. Fantastic journal if people want to check it out. And they have a section called Things We Do for No Reason, which is kind of a cheeky way of saying, what are some practices we do in medicine, usually clinical, but this one was education focused, that maybe don't have a lot of evidence to support them. And we wrote one about this toxic quizzing. I was really interested in doing this because in our medical education pathway here in Cincinnati, I give some lectures on how to ask clinical questions and how to ask questions in the clinical learning environment to help stimulate learning. And in it, I talk about some of the literature showing how toxic quizzing can have negative effects on learners and how there's not really a good evidence base that it helps learning. And every time there was some curmudgeon in the back, usually multiple curmudgeons, who would raise their hand and go off on a big, long thing about how they were toxically quizzed and it helped them. And that's why they'll never forget the histology of Barrett's esophagus or something like that. And it was just remarkable to me how many people still believed that intentionally causing distress in learners was a good way to teach. And so we pitched this idea and they said, go ahead and write the paper. So we wrote it. And what's fascinating to me is the same conversation is playing out on X now. So we wrote this paper, Journal of Hospital Medicine, wonderful journal, but it's not like Nature or New England Journal. I didn't think it was going to, set the world on fire, but it has been tweeted like crazy because so many people pick it up and say, this is garbage. I don't agree with it. I was toxically quizzed and it was good for me. Look at me. And I think there are a lot of flaws in what those people are saying, but it's an interesting conversation to have for sure. And at least hopefully some people think about it and reflect and say, oh gosh, I thought this was good. Maybe it's not.
I mean, I remember in our own orientation, we were taught about eustress and distress. I don't know if Michael remembers that, but eustress and distress from, no. Okay. It was very much included in the orientation and what our expectations were. And then as we grew from interns, full drink from a fire hose learners to more like trainee learners, and you're kind of interim as a junior, senior resident, that maintained, that there was some value to turning the screws while asking the questions. So it was not that long ago. I'd like to think that we were still actively being taught the value of it.
The fact that you remember that, Ned, is the reason why you're my favorite.
I also entered my work hours just for the sake of it. Yeah.
Yep. Yeah. The evidence is piling up on who
we all have our strengths. Okay. All have our strengths.
I'm the rule follower between Michael and I. That's, I think, the other important takeaway. Yeah.
So, but Ben, when are these people that are dissenting? Do they have any valid points? I mean, is there any validity to their argument, or is it just an argument over the definition of what we're talking about?
Yeah, I think it's both. So there's a rationale to it, right? It's not an irrational argument, with the idea being that if I put some pressure on you, maybe you'll pay attention a little bit more. Maybe it'll stick in your brain better because you're in this heightened emotional state. And there is some evidence that in life, when you have a highly emotional moment, that it imprints in your memory better. There's good cognitive science to back that up. And it kind of just makes rational sense that if I get you terrified of me, then you are going to pay attention to me, right? Because you're afraid. And so there's a rationale there. But the downside to that is, number one, when you look at actual learning, not just memories, but actual learning, once you put somebody in a state of threat, they actually don't learn as well. So the whole I can have a flashbulb memory when I have a traumatic moment, that's true, but it doesn't stand the same when you're trying to learn information. It can actually hinder learning. And what a lot of these people don't think about is downside effects of putting people in this constant state of stress. So Ned just said the words distress and eustress. One of the things that makes this so hard is everybody has a different line of how much stress is too much stress, how much threat is too much threat. And that is not a line that we can see on one another. Like, I can't tell where you're, for those of you that are listening into medicine, it's like a Frank Starling curve for heart failure. There's like so much stress that can be applied and then you fall off that curve. Yeah. Where's your optimal function? And so, there's so many factors out there that dictate when that optimal point is for people, that when you start intentionally causing distress with people and reinforcing hierarchy, I think more often than not, it causes harm. And it contributes to burnout, and it contributes to regret for being in medicine. And there's some good qualitative studies out there to show that. So if it's not an effective teaching practice, and if it's got a high chance of causing harm to people, why are we doing it? And instead, what I think we should do is try to create environments that are what you call psychologically safe, which means psychological safety is a space where it's not easy. It's not like soft. It is there. It is a place where it is okay to be challenged. It is okay to fail. And you can kind of dive into really difficult things and moments and not feel like you're going to be punished or there's going to be damage done. So we always say here, we want things to be safe, but not soft. You're going to be challenged. You might get asked questions here and there, but we're going to do it in a way that you don't feel like there's hierarchy and harm being done. It is safe to say you don't know. It is safe to get things wrong. That is different than toxic quizzing. And I do think, to your point about definitions, Michael, people conflate the things. There are some people who I see on X who read the article and they say, yeah, you can't ask questions to people. And like, no, that's not what we said in the article. We said you should ask questions. And we said you should, apply some level of stress to people, but do it in a way that is psychologically safe, which is very different than toxic quizzing. And I want to be clear, there are people who believe toxic quizzing, in the sense of making people upset, is a good thing to do. And this paper was written for them to say, I think you're wrong.
I've thought about this a lot, especially when I've worked with interns. There is an aspect, and not just interns, but really practicing doctors as well, of this basic, I don't know what it is, something that was ingrained in training of, to your point, not being able to say, I don't know. And so that's a sign of weakness for some programs to say, I don't know. And so what does it actually mean when you're out of training, you're taking care of a patient in a room, and what's been kind of burned into your clinical reasoning is, I can't say I don't know, is going to put that patient potentially in danger. If you can't admit that you need to spend some more time researching, thinking, discussing, looking into it more, instead of reflexively not want to show weakness and then giving some half-thought plan that projects confidence that then, you still get the respect or whatever feeling. That seems to me your approach would limit some of that behavioral maladaptations that some doctors have.
I 100% agree with you. There's some good research out there in Med-Ed that says, if you were to look at all the different attributes that people look for, and when you're ready to go take care of patients by yourself, what is like the number one attribute? Is it knowledge? Is it efficiency? Is it communication? Is it accountability? Those are all really important things, right? But the number one thing a lot of people agree on is that, do you know your limits and will you seek help? That's it. Because you have to be smart enough, you have to be efficient enough, you have to be a good enough communicator. But all of those things can be kind of made up for if you know your limits and you'll ask for help. And all of us have to do that, because even if you are the best resident ever, once you get out into practice, you're going to see stuff you've never seen before. Maybe you've cared for 50 people with pancreatitis as a resident. Then you get out in practice and you, for the first time, see somebody with hemorrhagic pancreatitis who's on a DOAC, and suddenly you're like in novel territory, and you need to be able to recognize, I don't know what's going on, and have the humility to say, I need help, and go ask for that help. And so I agree with you, Michael, that like, if we can start instilling that in people while they're learners and modeling that for them as supervisors, then that's the way to go, so that when they get out into practice, they don't feel like they have to fake it while they're there. And I think more and more younger attendings that I see, and I am going to put myself in the younger attending category, thank you very much. I think more and more younger attendings are getting better at that. I do think that kind of that false bravado, performative nature it still exists, but it is slowly washing out of medicine.
The I don't know part too, Ned, I don't know if you would agree with this. We deal with a lot of doctors outside of the clinical setting. And there are times when sometimes the competency to confidence ratio is off. And so the I don't know statement is a sign of weakness, not just clinically, but even outside of medicine, because we're doctors. We have to know everything. And then that puts you in all sorts of dangers financially. Like we see a lot of people not knowing their limits, not seeking help, making poor financial decisions, which then impacts their ability to practice or where they practice or who they see. And patients are, I think, negatively affected that way too. So I just feel like I say this all the time. Maybe you got it from you, Ben, but just the most important phrase is, I don't know, but let me find out, that you need to be able to learn as a doctor. And that should apply not just clinically, but also outside of medicine as well.
Yeah, I don't know if that was me, but it sounds smart, so I'll take credit. I think you're right. Even I will say in the financial world, I feel pressure to pretend like I know what I'm doing. My wife and I were recently looking for a house, and I'll admit I was embarrassed that I actually reached out to Michael to ask some questions. And I was kind of embarrassed to have to do that because I'm a 40-year-old man who's been in attending for 10 years. And I felt like I should know these things. But the reality is I've only ever bought one house in my life, and it was 15 years ago. And I'm not a financially savvy person like you all. So I agree with you. Like there's so many aspects of our life that if we just kind of put down our pride a little bit and say, I don't actually know, I'm going to go ask for help, I think it not only will you live a better life, but you'll start to see other people go, oh, you didn't know that? I didn't know that either. Like, I can't tell you how many first-time home buyers that I see that are residents, now that the housing market's starting to change a little bit and be more of a buyer's market, are like, this is really complicated. I don't know what I'm doing. And I'm like, you know what? I don't know what I'm doing either. Like, I've only done it once and it's really hard. So like, make sure you reach out to people who know what they're doing. And I think that's helpful to hear.
Yeah, I think I was lucky enough to be invited back and speak to my faculty group in Boston just about a month ago on retirement planning and investment planning. I'm pretty far from both of those things, and they just really wanted to start at the 101 level and make sure that they were covered. And I think it was a great moment to say, like, hey, no matter where we are in our careers, we can all just pause and take a beat and say, what don't I know? Like, how do I interrogate if I don't know what I don't know? And it was really fun for me, frankly.
I get the message, Ned. We will invite you back to Cincinnati. I get it. Boston loves you. Boston loves you more than we love you. Boston loves you more than we love you. I get it.
Pretty obvious. I miss the chili more than anything. If I could really, yeah. Sorry, that was almost a St. Louis twisting the screws on that. Let me, just for the fun of it, take a contrary position. Just for everybody out there, I don't necessarily believe this, but let's go this route just for fun for a second. How do you balance forgiving some of this, creating a safe space without it being a soft space, and a little bit of the, if you give a mouse a cookie, like as it starts to slide and the trainees ask for more, and the trainees ask for more comfort and more, because that is an argument that I've heard from people. Again, I don't believe, but I'm staking this position. If you start cutting work hours, you'll cut more work hours. If you start creating safe spaces, the spaces will get ever safer. How do you balance that and make sure that you're still getting the objectives across and not creating safety or softness for softness' sake?
Yeah, this is a great question, and I'm not going to offer any definitive answers, both because I don't have one, and I think this is a hot button issue right now in medical education broadly. There are two things I'll refer people to if they want to do more reading on this. One is there's a really widely discussed article by Dr. Lisa Rosenbaum in the New England Journal of Medicine called, I believe it's called Doing Well While Being Well, or something along those lines. And it starts to get into the idea of, as our understanding of harm and trauma in the learning space evolves over time, how do we navigate the boundary of what are necessary discomforts, what are unnecessary discomforts, and what is trauma? Now, some things are clearly trauma, right? Like racial microaggressions, gender microaggressions, or macroaggressions, all of those things. But then there comes a point where it's like, okay, if we make training too easy, or if we just kind of bend everything toward comfort, do we lose something? And more importantly, are we not preparing people for the real world? Because as both of you know, being a physician out in the real world. While residency is hard, being an attending is just as hard. And so that line is not clear, but the discussion is a really challenging one to have, because I think it is in tension with the well-being movement that we've been trying to navigate through in the last several years of like, we want to promote well-being for people. It's really, really important. And at the same time, we want to have rigorous training. And sometimes those things can feel like in conflict, but I think we have to try to make it an and, not an either or. So that paper kind of navigates that tension. And like, I think there's not a clear line, and it's different for everybody, which makes it really challenging. So you'll see, I think, let me just back up and say one more thing that I think makes this challenging is we tend to be anchored in the paradigm in which we trained. So in other words, what is like enough discomfort for me is very much anchored to what I went through in training. And you all are probably the same way. And I think the window on what is necessary discomfort or too much easy or too much soft changes over time. And we are left anchored in one point in time. So the window can start to pass us by. And I think that's how you get people who, you're the old man screaming into the wind, and you're kind of outdated with where people are on things. And so I think the best thing is to remain humble, to talk to our learners as they are, to look at the outcomes of training and try to find that optimal balance of promoting well-being, meeting learners where they are, listening and responding in good faith, and following the outcomes of training. And if you start to see that people are not getting to where they need to go, again, that competency-based approach, then you have to have a really hard discussion of, if we're changing training to reduce work hours or to reduce your exposure to work compression and things like that, how else can we make sure that you are going to be ready for the work that you're in, the life that you're going into? Is it extending training? Is it having work compression and long work hours, but maybe in shorter bursts? I don't have the answer, but I think we all have to come to those conversations with humility and curiosity for sure.
Yeah. One question, just as you mentioned in time variable training, and we spend a lot of time on time variable training, but one of the aspects that's so interesting is just the calendar of medicine is so rigid, right? July 1st is such a conserved date. June 30th is such a conserved date. How do these groups reconcile time variable training? Frankly, when you're signing your next contract 6 to 12 months ahead of that presumed graduation date?
Well, I think that in the pilots that happened, some of them did what's called promotion in place for people who went faster, which is kind of what you were talking about earlier, where you stayed at the same institution, but you got advanced levels of autonomy. So you could function as an attending in your own institution before you went on to graduate. And other programs actually were able to graduate people and have them move out a little faster. In fact, a really interesting thing that happened around the time of COVID was there were a lot of medical schools around the entire world, the US and other countries, who let their medical students out as early as February or March, to go and help with the pandemic in 2020. Exactly. They could actually go deliver care in some way, and then they would go into their ACGME programs in July. And that made a lot of people say, why are we not doing this all the time? If we were allowed to let them go now, why are we making them stay? So I think there's lots of different models and ways you could do that. The other thing is, everything is very much married to the match, the NRMP match, which if people are listening are not familiar, the way you get into a residency program is there's this once a year thing that happens where you submit to this big process and you get all at one time with everybody else in the country linked to your residency program. It's called the match. And even medical school admissions tend to happen like a once a year type of thing. It doesn't have to be that way. In fact, there are other countries who have what you would call a rolling match or rolling admissions, where it's not every single day you're doing a match, but there are like on-ramps and off-ramps at different times throughout the year, which maybe makes this time variability idea a little easier, both in terms of off-ramping somebody earlier or later, but also in terms of it's that kind of mindset and focus on, am I moving faster or slower than other people, gets lessened if you're all starting at different points. Right? It's like if we're all running a race, but we're all starting at different points, I'm not comparing myself to you as much because I don't know where you started. And so I think if we, again, rethought fundamentally, what does our education system look like, which would then have to go back to how is it funded? And I mean, there would be a lot of changes that would have to go into it. You could imagine a much more flexible system that includes on-ramps and off-ramps rather than this high stakes once a year, moment.
Can I go back to the toxic quizzing real quick? I just, as a thought experiment, was thinking about this. If we're so outcomes-based and evidence-based, just hypothetically, if there was a study or series of studies or enough data that actually showed that toxic quizzing made you a more competent doctor, do you think you would adopt that? It's just like a funny thing to think about. How do you, like for me, I never did that as an attending. I still don't. And if the evidence came out, or like, actually, we should be doing this as best practice, I just don't think people would change. And I guess the reason I bring that up is because I think on the opposite side, it's probably hard for a lot of people that just don't know how to teach outside of that to ever change, no matter how much the evidence stacks up against them.
I would rapidly adopt it, mostly because I'm filled with rage and I love screaming at people. In fact, you mentioned that I'm getting my PhD. It's mostly so I can have that sense of superiority. And so that would very much align with, if there was evidence to say, hey, make this other person feel worse, it would just be like unleashing my inner Hulk. But in seriousness, I think that it's an interesting question. And I think I would also want to know, because I want to be open-minded to that, by the way. Let me be clear. Maybe there are studies that will come out that show if you really, really make somebody uncomfortable, really kind of make them upset in some way within, HR allowable bounds, that they learn better. If that came out with very compelling evidence, I think that would be a really interesting conversation to happen. And I think two things would be important. One, did they look at the negative consequences of that? Like, yes, you made them learn faster, but did you make a bunch of people have to like start medication because they're stressed out of their mind? Or quit or whatever. You push them into a depression. And two, like how big was the amount of efficacy? Did it, how big was the help? So the downsides and also how big was the advantage to it? But yeah, like I think that would be an interesting question to study, and I would be open to hearing that evidence. When I wrote the paper, I wasn't starting with the conclusion I like being a nice person and I want other people to be nice. I was starting with, I have seen so much harm come from this practice, and so many people are convinced that that they are doing it as a like kindness. In fact, there's an article that we cite in that paper written by a surgeon he's like extolling the virtues of toxic quizzing. And he describes it as like a vaccine where it's like, oh yeah, vaccines hurt, man. That needle hurts, but it's for your good. It's your long-term, well-being. It's going to help you in the long term. And I think that's just very flawed thinking. But if Panacea Financial wants to fund that study, I'm happy to find some people to scream at some residents, and we could do that.
It's interesting. So what I hear you saying is you're not a fan of Kelly Clarkson's song, "What Doesn't Kill You Makes You Stronger."
No, she coined that phrase too. It really is a Clarksonism.
I am calling Kelly Clarkson a liar.
Okay,
I think she's a liar.
She should be. Wow.
I think she should be taken off the air. She's quite charming. I think she's a wonderful on-air personality, but I think she's gone too far. And I'm glad finally somebody's calling her out for it.
Wow. We're making news here on the podcast today.
Kelly, I'm coming for you. I'm coming for you, Kelly.
I'm sure we'll get a response. Maybe we have her on the podcast to have a good debate. I know we're kind of wrapping up. I know you're a busy human being doing lots of stuff, and I want to respect your time. But I did have one question, and Ed, I think you had another question too. But one of my questions that I really like asking people, especially folks who are so thoughtful and like yourself, is what is one opinion that you hold as a doctor that you think a majority of doctors disagree with? Maybe you don't have any of those. We already kind of hit on a couple, so I've taken a few off the list maybe, but is there anything that comes to mind maybe that you think that you hold that most doctors would say, no, that's crazy?
Does the mint chocolate chip count?
That probably is the majority position, actually. So I would not allow that to be a appropriate answer.
Oh, okay. I do think that the toxic quizzing one is one of the biggest ones that I get pushback on. A lot of my other views kind of align with what most people think. I do think that there are a lot of people, and I'm not going to go too far down this rabbit hole, but a lot of people in medicine have a worldview that you would call what's called positivist or post-positivist, that there is a real truth about the world and we can measure it with whatever. And as an educator, I actually don't think that's true. I don't think there is an objective truth about people's competence or intelligence or any of those things. I think those are all socially constructed things. And that has some pretty big ramifications for how you go about trying to do education. And I think there are a fair amount of educators who would agree with that position, but I think the vast majority of doctors don't think in those terms. It's a very social sciences way of seeing the world. And I'm a social science kind of guy.
Interesting. I don't say that sounds too crazy to me.
Well, thanks, Michael.
It does not sound too crazy to me. No.
I think the other thing that, and I think most educators would agree with me, but most doctors would not, is there's a big thing out there about learning styles. Did y'all ever learn about learning styles?
I learned it. I learned it in a recording, an audio, but I'm just not a good learner in that. Yep. I don't think I retain.
Yep. Yeah. I think learning styles are not very meaningful at all. I think we, they're a thing and that people talk about them, but when people say I'm a visual learner, I'm an auditory learner, I don't think that actually has any bearing on how well you learn things. And there's a good amount of evidence to back that up.
Spicy take, Dr. Kinnear.
I have one related to you being a social scientist, because this is one that does go back to, I heard it as a Dr. Warmism, and I mean that with all love and respect to Dr. Eric Warm, the internal medicine program director while we were there, about whether you are a white or dark cloud, whether you believe you are a white or dark cloud, you are. And that it's the belief that drives ultimately your happiness and your feeling of, frankly, whether the work is putting upon you or not. And I know this is an area you've looked into, and so I wanted to get your spiciest comments on it.
Well, you define it. I think there's some people, like I've kind of come across, if you trained at different programs, they call things different stuff. So
let me describe my my understanding. And by the way, when you say you've done work on it, I've not done research on this, but I'm with a group of people currently writing a paper about it. So in a lot of places, white and black clouds, the idea is that it is your cloudness is a marker of like things that happen to you when you are in the clinical environment in terms of like your workload that you face, the amount of crazy things that happen to you. And white clouds tend to have an easier time with lighter workloads and fewer kind of disasters happening. And black clouds have more bad things that happen. Now, I want to be really clear, by the way, I do think this is another example of like white is good, black is bad. So just for anybody who's listening, I actually think there are some problematic things with this particular terminology as well, but it's certainly it's something you'll hear everywhere in medicine. I'm a white cloud, meaning, I go through call and I have an easy call, and I'm a black cloud, meaning I get crushed every time I'm on call. So it's kind of a superstition. And the kind of inherent belief is that there is like an external force in the universe that is happening to you, right? That's the classic belief. And there have actually been people who've done studies on this to say, if you identify as a black cloud, do you have more workload, whether it's more admissions or more pages or more codes, whatever. And if other people identify you as a black cloud, do you have more bad stuff happen to you? And the short answer is no, it's not a real thing. There is not a measurable difference depending on your cloudness. And so then it's just interesting to think about, why do we hold that belief? Like if there's no evidence to back it up, why do we hang on to that? And I have a couple of theories that have to do with things like hedging. And if there's something called Pascal's wager. I don't know if y'all have ever heard of it, but Pascal's wager is basically like, if there is a God, it's better to believe in God, because if you are wrong and there is a God, eternal damnation. And if there's not a God and you believe in God, nothing happens to you. I think cloudness is a matter of, it's better to believe in cloudness and not say anything bad about the universe, because if you're wrong, the universe will punish you. And so I think it's all about a superstition. And it's interesting, when I had this discussion with our residents at a Med-Ed pathway, I said, who all here believes in cloudness after the talk? And I showed the evidence, and very few people raised their hand. And then I said, how many of you will go back to the call room and say, we're going to have a quiet night tonight? And none of them would say it. Everybody kept their hand down. And it was just fascinating that like, we can know that it's not a thing and that there's no universe cloudness thing here to punish us if we identify as black or white clouds, and yet we're still kind of afraid of it. So I'm fascinated by that facet of our psychology, because it's got to serve some kind of purpose. So why do we hold on to it?
Well, Dr. Kinnear, I think we could probably talk to you for 2 or 3 hours, but I know you don't have 2 or 3 hours, or maybe you don't want to talk for us for 2 to 3 hours. And 4 years of residency was enough. Either way, We are very honored for your time and love hearing your thoughts and opinions. And it's always fun on a personal level for us to get to talk to you. I did want to give you an opportunity because I know people might be hearing of you or about you for the first time. If people want to learn more about you or your works, where can they find you online or anywhere? Not your home address.
I am on social media. I'm on X, formerly known as Twitter. I'm on Instagram too, but I'm not on there very much. And otherwise, I don't really have an online footprint. I will just say, what a fun treat to get to chat with both of you. In all seriousness, you were both amazing physicians and educators and advocates when you were at our program. We really miss both of you. And not only is our program proud of you, because it's so cool to see what you've gone on to do and how many people you have helped with your company and with all that you do, but I am personally proud of you. I'm really proud to get to say that I was part of your training, even though I mostly just watched while you all did your thing. You didn't really need any kind of help or guidance, but it's been a real treat chatting with you and to just see all the things that you do. So thanks for having me on.
Thank you. We recorded this entire thing just for that validation. I've been needing it for years, Ben, so I appreciate it.
That's awesome. Thank you, Dr. Ben Kinnear. Appreciate it. I love getting to talk to Ben, and he has some very interesting takes. What did you think? Did you learn anything, Ned?
I learned a ton. I've always learned a ton from Dr. Kinnear. I remember on my interview day, I think we both actually interviewed with Ben differently when we came through on our interview days for residency. And so knowing him for as long as we have now, in the regard that I hold him in, I really enjoyed this conversation about where we really ought to be looking at going in medicine, what the potential pitfalls are, how we can shore up residency trainee and make sure, frankly, that we're creating better doctors, not just doctors who did an amount of time as though they were incarcerated. That's not rehabilitation, and it's certainly not training.
Yeah, I think it's all rooted in outcomes and what actually works and what doesn't, and trying to measure what works and what doesn't, challenging the status quo, which is what we do in science anyway. So why don't we do that in education for doctors? It's a very lively debate. If you look online at some of the topics he talked about, which is time variable training, can a resident or fellow or medical student, dental student actually graduate earlier because they've shown competency? A lot of opinions there, a lot of problems, a lot of potential issues. The appealing thing is, especially on the school aspect, I've always thought this, is in medical, dental, and vet school, if there's time variable training, potentially you can save a lot of debt to a lot of future doctors, which allows them to practice unencumbered. This is a pipe dream, but I think it's a very interesting idea that needs to continue to be explored. The other thing is this toxic quizzing. Ned, did you have a lot of that in your med school and residency? Were you subject to a lot of toxic quizzing?
I was while standing next to you on wards. Yeah. What are you talking about?
I just wanted to make sure
we were on teams together.
It sounds vaguely familiar, but I think that what I like too about Ben is, as you know, for the spirit of academic honesty, if there were data that said, hey, actually toxic quizzing is really great for learners, it's a net positive, we produce great doctors, then he would have an open mind to say, hey, let's think about adopting this. I think all of us probably know deep down it probably isn't a net positive in training doctors. It's probably always going to be a practice that some people do because, again, here's what I experienced when I was in residency or med school, or here's what someone told me someone else did. But the challenge really is, does it work? And the other thing we talked about, which I think is appropriate, is what is it? How do you define it? What some people might call toxic isn't, and what some people think is appropriate, some other people don't. So that's a little squishy on the definition, which can make measuring it hard, make standardizing, applications of it, I think, pretty difficult too.
Yeah, there's a lot of subjectivity and trying to understand what the metrics that you're measuring around are. And certainly Dr. Kinnear spoke to some of that at the end, the social science aspect of it. I also, going back to whether you would or wouldn't participate in this, do you wear a white coat?
I wore a white coat my first day of residency and never again. I hate white coats, personally.
The infectious disease doctors love you, but the patients, right? You can have compelling evidence, but does that make it actionable at the same time? And if it's weakly compelling, like the white coat evidence often has been, that there's a slight positive bend towards it, will that be enough to change practice? in some cases, I would hope when it comes to, toxic questioning and what they're looking at, prevention of harm is, I think, much different than patient preference. And so I would hope that we'd bend medicine a lot more around it. I'm guilty. I wore a white coat for the first year, and then I looked at myself in a mirror, and at 6'7" in a white coat that only came down just past my elbows, I realized I looked not like the look I wanted to put out there. So I made the same decision.
That's right. No, I think it's a great point. I don't know what evidence it would take for me to be like, yes, I'm going to wear a white coat, just because I've practiced this way. I have a routine. I really don't like it, but it's a good thought experiment. And I think what, at least again, I appreciate about Ben and also a lot of his other med ed researchers is really focusing on what works, what doesn't, what can we throw away, what can we change. Hopefully there's more and more progress in that direction that ultimately makes a system that produces not only more competent doctors, but less burnt out, less stressed, and happier doctors, quite frankly. And although some might listen and say, oh, he wants everybody to be happy. I do, but I also want doctors that can continue to practice, that can continue to see you and your family. We all are patients here listening. So we need doctors that want to stay in medicine, that want to stay in dentistry and in veterinary medicine to continue to treat people we love, or animals we love in the case of vets.
Of our veterinary colleagues. I think of the word engagement a lot, of what's the level of resident or med student engagement. I think we've all seen those moments where somebody is getting toxically quizzed or in some other ways like beat down upon. And it's so obvious when a wall goes up or something gets shut down. And so maybe, like Dr. Kinnear says, a small piece of memory sticks, just something that's rote memorization. But what do you need as a doctor in terms of synthesis, analysis, being able to make clinical decisions? And when all that goes away because just immediately a wall goes up, your level of engagement goes way down. So I'd love to see more engaged learners, more engaged residents. And a lot of that does have to do with the time and competency and the way that we train our doctors. Instead of making them feel safe, the willingness to say, I don't know, but I'll look it up, that's not a negative, but actually a positive. And just making sure that the residents, trainees across all the different fields that we support are supported.
Yeah. Well, a lot to think about, a lot to learn. And the exciting part is it's always changing, so it doesn't stay stagnant.
Thanks for joining us this episode. You can catch the podcast For Doctors by Doctors on Apple, Spotify, YouTube, and all the major podcasting platforms. If you enjoyed this episode or learned anything here today, please take a moment to give us a rating and subscribe so that you don't miss a single episode release. As always, thank you for listening. And the next time you see a doctor, maybe you should prescribe this podcast. We'll see you next time.